lasers for normal and complex corneas. I have no financial interest in this talk. So traditionally we've looked at wavefront guided and wavefront optimized as ablation profiles. Wavefront optimization basically maintains the corneal asphericity, and wavefront guided treatments are aimed at treating the higher order aberrations. With the advent of topo-guided technology, we've been looking at using topography to address both the corneal higher order aberrations and improve visual acuity and post-operative quality of vision. And traditionally it was thought that the advantages of topo-guided treatment were more in highly aberrated or irregular corneas, scars and other conditions like keratoconus. So I'm going to divide the talk into aberrated corneas and normal corneas, and let's go through a few examples of this. And I know that Dr. Gaurav is going to go into details of other cases as well. So typically this is a patient with keratoconus. You would traditionally treat it with C3R to stabilize the condition, but a lot of patients had visual acuity which was suboptimal after just a C3R. So along with C3R, combining topo-guided lasers has been thought of. So where do we stand in terms of this? You have to be careful that the corneal thickness is good enough for that, because if it's less than 400 microns, then of course combining it with any kind of laser tends to be contraindicated. So if you have a good corneal thickness, then this is one of the options. Of course, Intax is another option that Dr. Vikas so wonderfully elucidated. So initially the treatment protocol was described, which talked about looking at removal of a little bit of epithelium with a transepithelial laser, followed with cross-linking that had the effect of shaving off the cone. Apart from that, there are these various different protocols that have been described. The Bharat protocol by Dr. Rajat Jain is a protocol on the Nidec machine, and of course the Athens protocol by Dr. Kanilopoulos. So let's look at an example of this patient who we did a topo-guided PRK with cross-linking. This was a 26-year-old IT professional. And what you can see is in the right eye, this is the pentacam, and it shows a high cylindrical refractive error. Best corrected visual acuity was 612 in this patient, and he wanted to know whether anything could be improved. He didn't want to wear contact lenses, and that's one of the first questions to ask in these patients. So we went ahead with the topo-guided planning. It's important to export good quality images from the Topolizer Vario into the treatment software. What we first do for these, as you can see in the screen here, is you would set the refractive error to 0. So you can see that even with 0 refractive error, there is about 24 microns of central ablation and 43 microns of maximum ablation in this patient to regularize the cornea. I've kept the optical zone less to ensure that we are not treating above the limit of 50 microns, because again that would cause further thinning of the cornea, and again the C3R may not work as effectively in this. Following that, what you tend to do is to slowly increase the cylindrical correction. So what you can see is that even when I bumped up the cylinder here to about 1.75, the central ablation is just increased to 29 and the maximum to about 44. So in increments of 0.25, you can keep increasing the cylindrical correction. This shows when I bumped it up to about 2 that it's 30 and 45 microns. 2.25 takes it to about 31 and 46. And about 2.5 takes it to 32 and 47. So this is what we settled on finally. The other thing is to max out the transition zone that you can see there, because you do get sometimes a peripheral hyperopic scarring following this laser ablation profile. So this is what we settled on. So this was the post-operative pentacam. As you can see, along with the Intax which Dr. Vikas showed, even in this you're effectively peripherally pushing the cone down. So the best corrected visual acuity improved to 6/6 with a 2.5 diopter cylinder, and this is the post-operative outcome, which stayed fairly consistent for about 6 months post-operatively, which is the follow-up period for this patient. Now, topo-guided PRK, of course, you can plan in certain cases where you have corneal thickness, but then there are cases where even with a 0 ablation that you can see over here, the ablation is crossing 50 microns. So in those kind of cases, it's very important not to go ahead with it, because you could end up thinning the cornea too far. So this is an example where sometimes wavefront optimized can also be used. I know Tushar is here. We've done a couple of cases on the old Vizex machine with wavefront guided. The only issue with that is to get a reading is sometimes difficult in a keratoconic patient. And of course, these profiles, you can see that just for regularization, the amount of ablation is much less with a wavefront optimized, and that could be done in this particular case. So the aim is regularizing the cornea, reducing the corneal aberration profile, improving quality of vision, and reducing ghosting, shadowing, and night halos, which can be achieved both by topo-guided and by wavefront in a selective number of cases. This is also something that has been published by the NN group, which is on using the Schwind laser, the Amaris, to do a customized PTK over the particular area of cone. So the Amaris enables you to decenter your ablation in a PTK, which may not be possible in say the Alcon machine. But what you can do is localize the cone on the anterior tangential curvature map, mark out the dimensions of the cone, identify the long and short axis, and then perform a PTK. The PTK, along with that, you take about 20 microns additional of stromal ablation, so you're essentially again shaving off the cone. This is like a modified Cretan protocol. And then follow that with a manual removal of epithelium up to the 8 mm zone and do a cross-linking. So this also has been shown to be effective, especially in patients who have a higher coma or a slightly decentered cone for treating this. So coming to why we thought about using topo-guided treatment for normal corneas was it was working well in these aberrated corneas. So then the concept was whether to use primary topo-guided treatment for myopic correction. Essentially, this is how a topo-guided treatment works. It detects the Myers, the pupil margin, and the apex of the cornea, calculates elevation data, selects the median image. It does a best fit A-sphere which is subtracted, and then uses peripheral energy compensation to customize the spots, to regularize the topography and maintain the shape, and to correct the refractive error. So the burning question is whether topo-guided ablation is as effective as wavefront optimized in treating myopia and astigmatism. The advantage of topo-guided treatment is it's not limited by the pupil size, unlike wavefront-guided or wavefront-optimized treatments. Correction of errors produced by more peripheral aberrations can be taken care of. It's not subject to errors by the internal lenticular changes or vitreous opacities, etc. And it's not affected by the state of accommodation. The drawback is that it doesn't take into account the posterior cornea, etc. And you would have to kind of compensate for those things. So with that in mind, again, we were discussing on this a few times, and Dr. Gaurav actually introduced me to the Faucet's software along with Dr. Dhami. Abhinav actually introduced me to this. So we'll just go through a couple of case examples of how we use the topo-guided to do the planning in these cases. So what you can see here is that there is an astigmatism of about 1 diopter in this patient in the right eye and about 0.4 in the left eye. Looking at the right eye's treatment, this is the Faucet's software. It uses geographic imaging systems which are used in basically geology. So it's trying to import this and give you a compensation. What you can see in the screen is that there's a target refraction that you set, so you would set that typically to 0. There's the manifest that you would get from your refraction. The Contura recommended treatment is what you get from the topolizer. So if you look at this a little bit further in detail, this is what it images. These points that you can see are what are called taluses. Taluses are basically areas where there's the topography is showing a change. The software maps out the height, the location, and the area of these elevations in the topography. So that is what it's actually capturing. Apart from that, what we have to feed into this is also the anterior corneal astigmatism from a Scheimpflug device along with the Placido. So it actually combines Placido and Scheimpflug technology to suggest the treatment in this. The reason is that anterior corneal astigmatism, when you're treating it, you are also going to be treating some amount of the higher order aberrations by compensating with your cylindrical correction. You don't want to do an overcompensation for that, because that can sometimes lead to suboptimal results, which is what happened with the traditional Contura treatment, where it was used for non-aberrated eyes, but when you had higher order aberrations, those were interfering. So essentially what you do in this is you use the anterior corneal astigmatism and the posterior corneal astigmatism from a Scheimpflug like the Pentacam, and you feed in this data as you can see here, along with the manifest refraction and the Contura treatment. What it also does is then it assigns a vector. It assigns magnitude and amount to each of these astigmatic corrections. The total astigmatism which is coming internally is derived from the fact that you already have the anterior corneal astigmatism from the Placido and the Scheimpflug and the posterior from the Scheimpflug. and the total is taken care of by the manifest refraction. So you subtract those two and you get the internal corneal astigmatism. It also does a spherocylindrical correction, as you can see here, that there is a change in the spherical that the Forsythes is actually recommending based on the cylindrical correction, because the assumption is that your mean refractive spherical equivalent would stay the same even if there is variation in the amount of cylindrical you are treating to take care of the higher order aberrations. So that's why it gives you that value of minus 1.56 with a minus 1.87 cylinder. The axis is matching reasonably well. And this is an overview of the printout that actually comes from the Forsythes software. So again, we went ahead with this. You can see the imports of the images. You set the values to 0 in the sphere and the cylinder. And then when you feed in the Forsythes values, you can see what ablation profile it's giving. Just to highlight what the wavefront optimized was, and this was a slightly different profile. If you can see the two images, there's a difference in the profile that it's giving you. And it's obviously recommending a different sphere and cylinder. So with that, we went ahead with the topo-guided treatment, and of course, we achieved a good visual acuity. We've also done, when I was at NN, we did a study of one-eye wavefront optimized versus one-eye topo-guided treatments, just to see how they were working in patients with comparative refractive errors in both eyes, the patient being fairly similar. So one eye was treated with topo-guided, one eye with wavefront optimized. What you can see is that there was no statistically significant difference in the sphere, cylinder, the corrected or the uncorrected distance visual acuity after treatment in the two groups. When we looked at the Q value or asphericity, again there was no significant difference, although the wavefront optimized showed a slightly higher change in Q value for each diopter treated, but that was almost insignificant. It was about 0.01 difference. And regarding the aberrations, we found that there was significantly better control of the aberrations with topo-guided treatments versus the wavefront optimized in the one-eye study. So to conclude, wavefront optimized and topo-guided ablation profiles are good for correcting lower order aberrations. Both procedures maintain asphericity. Topo-guided ablation in virgin corneas induces significantly less positive changes in higher order aberrations. And of course, topo-guided treatments have the advantage of being used in aberrated or abnormal corneas conditions like keratoconus or scars, etc. So, thank you. That's my acknowledgements.
Thank you. If there are any comments or questions, meanwhile, Dr. Gaurav, I request you to please set up your presentation. I request Dr. Anand Vardhan to please give the memento to Dr. Rushad. Are there any questions or comments?
Yeah, just a quick question. Okay, that was a beautiful presentation, Rushad. Just wanted to ask you about, you were talking about the topo-guided CXL. So, how often do you get haze after doing that?
So, I haven't seen excessive. Now, obviously, my numbers of topo-guided CXL, I would have done only about 10 eyes, considering I've been in practice for about 5 years. The criteria I'm pretty stringent with on that. So, haven't seen too much haze, but I do use mitomycin as part of the protocol as well. But haven't seen.
So what is the cutoff? So do you see the good quality maps even at 57 diopters, 58 diopters, those cases? So
you're talking about keratoconus?
Yeah, that's right, keratoconus. So we are talking about keratoconus. Where do you want? So sometimes you have 58, 59 diopters, but your package is good, where you feel like you can do it. So what I found is getting those quality maps is a real challenge.
It's difficult, sir, but again, then you kind of just see which maps are reasonably okay for the treatment. Again, these patients, keratoconus behaves very strangely. It's not a direct correlation. So where we can do it safely and we have a reasonable quality map, I would say it's okay. If it's not affecting more than 2 quadrants of the measurement, then I do go ahead and plan it.
And in the cases that you have done, because you have shown some really good results, so do you use cretin plus ethins? So do you remove the
transepithelial PR? So I've done both actually. I've done a couple of patients with manual removal and a couple of patients with the transepithelial, but the transepithelial seems to do a little bit better overall because it does have that effect of shaving off the cone area.
So what we generally do is we see the epithelial map.
Yes.
So if the difference is good, like difference is 15 microns or so then the general results are very good. If the difference is less, so on the cone, so then that doesn't.
Then it doesn't make a difference. Normally, you'll see that donut pattern in case of keratoconus, where there is a thick epithelium or a peripheral central difference. Then it makes a reasonably big difference. Thank you.
And do you take the axis, like if you're planning to treat, you take the axis from the topo guided, or do you take it from the manual? Suppose, so these patients sometimes have very good refractions also. So they're almost like in your brain also you're attempting a sort of LASIK for them. It's sort of that. I mean, you always don't, you under promise and over deliver. That's the whole idea. But what do you prefer? You prefer treating what the patient is accepting, or do you prefer treating what you would be getting?
So funnily enough, again, this varies based on what ablation you're getting also to an extent, because sometimes on the topo-guided axis you get a very massive ablation comparatively. If that is the case, then I do go with the acceptance. If they are reasonably matched, then I would stick with the topo-guided. I didn't show an example of that, but there are cases where you just put in, according to the topo-guided, the topography astigmatism, and the ablation is much higher. It would be 20-30 microns higher, where you can't actually do that.
For me, an extra guided is that